Hi everyone, and welcome to the second webinar in this series, Women and Arthritis. And you're all very welcome, and thank you for joining us this evening. And we are delighted to have you all here today. So we're going to get started straight away. We know a lot of people are probably busy and want to get back to their various things in the evening, so we won't delay it too long. We'll keep going. My name is Tara Regan, and I'm Communications and Advocacy Manager at Arthritis Ireland. So just a little bit today about the two speakers that we have and presenters. We are absolutely delighted today to have Celine O'Brien and Louise Moore with us. Celine works as a clinical midwife specialist at the National Maternity Hospital in Holles Street in Dublin. And she originally trained as a nurse in St. Vincent's University and worked as a nurse for over 4 years before commencing a diploma in midwifery at the National Maternity Hospital and GCD. After that, she worked in the antenatal clinic for several years with a focus on maternal medicine clinic. And Celine also undertook a postgraduate studies, including the prescribing RCSI course. And she is registered with the Nursing and Midwifery Board of Ireland and as a clinical midwife specialist in 2018. So thank you very much for joining us today, Celine. We're absolutely delighted to have you here with us. And then next to Louise Moore, and we're also delighted to have you with us as well, Louise. Thanks so much for joining us this evening. So Louise works as a registered advanced nurse practitioner in the Rheumatic Musculoskeletal Disease Unit in Our Lady's Hospice in Harold's Cross in Dublin. In 2013, Louise was awarded with an MSc with the title Pregnancy and Inflammatory Arthritis, a description study of clinical practice and patient experience related to medication management and care from Trinity College in Dublin. And Louise is currently a PhD candidate at the School of Nursing and Midwifery in TCD, and she's evaluating optimum care models for this patient cohort. So I think it's fair to say we're in very safe hands this evening for our topic, pregnancy and arthritis. I just wanted to mention a couple of small points about Arthritis Ireland. We are the national charity and patient organisation for people living with arthritis, and we deliver support, training, education and information. Our website is arthritisireland.ie. On our website, you'll find a range of information booklets. You can book our self-management programs, and you can also find podcasts, recordings, indeed webinars from previous events and recordings with clinicians and blogs. We also have a free national helpline, which is open Monday to Friday from 10 to 4 p.m. And the number there is 0818 252 846. Just a quick mention of the VHI Women's Mini Marathon, because it is a Women and Arthritis webinar series. If you would like to support those ladies who are running on behalf of Arthritis Ireland, you can click and scan on the QR code on the screen, or you can do so by visiting our website. And we just want to wish them all the very well when they take place over the June bank holiday weekend. And then just a few notes, just to say this webinar is recorded. It'll be available to view on our YouTube channel from tomorrow. Everybody but the presenters and speakers are on mute and cameras are off, and we've allocated 15 to 20 minutes for Q&A at the end, and we'll answer as many questions as we possibly can. But throughout the presentations, you can add your questions into the Q&A function in Zoom, and like I said, we'll do our best to get to as many of them as we possibly can. There are also two additional webinars in this series. Next week, we have one about menopause and arthritis with Mary Gillespie. And then on the 5th of June, the final one, self-management and lifestyle medicine with advanced nurse practitioner, Una Martha. So without further ado, I'm going to hand over to Celine to kick things off. And thanks again, Celine, for joining us.
No problem, Tara. Thanks so much. So good evening, everyone. As Tara said, my name is Celine and I'm working in the National Maternity Hospital. I'm going to open up the talk this evening between myself and Louise. I'm going to start it off talking about pregnancy and family planning in the context of chronic illness. This really is particularly relevant, I suppose, for people living with arthritis and rheumatic disease, because planning for pregnancy does require a thought out, well-supported approach. So over the next few minutes, I'm going to just take you through why it's important, what steps to take before planning a pregnancy, and what then to do when you do become pregnant. So the importance of addressing reproductive health in chronic illness. Reproductive health really is a very important component of overall health, but it can be under-discussed in people with chronic conditions. So for people with arthritis, pregnancy can bring its own unique challenges. Disease activity, types of medication, medication safety, and fertility can all play a role. So if we integrate reproductive planning into routine care, people can be empowered to make informed choices. This can all help to reduce risks and also promote autonomy. So it's very important for us all to address reproductive health, and particularly for women with rheumatoid disorders. I think, and there's a big discrepancy between maternity care and general pregnancy care. So we, I suppose, are trying to kind of bring these together.
Sorry, Celine, do you want to just click on from beginning or from current slide there, just so that it goes into presentation mode?
Oh, yeah.
Yeah.
Yeah, perfect. Sorry now.
No worries at all.
So just then starting off really with the basics when it comes to preconception, folic acid. So it's a very simple one. I suppose we will have all heard of it, but it really is a non-negotiable for people when it comes to planning a pregnancy. Really the reason behind it is to help reduce the risk of neural tube defects, such as spina bifida and anencephaly. Most people will only require 400 micrograms a day for the 3 months before becoming pregnant, but in certain situations, people will require 5 milligrams. So this is where you would see your GP or healthcare professional for that prescription. This would be women with diabetes, people with a body mass index over 30, if you're celiac, or certain medications such as sulfasalazine. We would advise people to take extra dose folic acid before becoming pregnant. Again, balanced diet and healthy weight. And these are all things, I suppose, that we are aware of and we are told, but it really can't be talked about enough when it comes to planning for pregnancy. Nutrition really does matter, eating a healthy, balanced diet. And for most people, we will be able to obtain all our vitamins and minerals from a healthy, balanced diet. Apart from the folic acid, you wouldn't necessarily need to take anything else in the preconception period. As regards weight, again, something that people are very conscious of, I suppose, in modern times, a body mass index over 30 or a body mass index even under, say, 18.5, both have their own challenges when it comes to fertility and pregnancy, so can increase the risk of gestational diabetes if it's a high BMI, or it can reduce the risk, increase the risk of intrauterine growth restriction if someone has a very low BMI. So it's important to try and work on optimal nutrition and body weight before becoming pregnant. Physical activity, again, is an important thing. It's important for us all, I suppose, to stay active. Staying active does improve cardiovascular health. It can help reduce stress. It can help support fertility and positive fertility. So it's important to try and aim for 30 minutes of moderate exercise most days. Again, activities as described. Especially for people with rheumatological disease, it's often a complementary therapy to whichever rheumatological disorder someone may have. Strength training can help improve symptoms, can help improve joint mobility. So exercise has got a lot of positive benefits. It's also got positive benefits on mental health as well. Lifestyle modifications, then again, the standard things, I suppose, again, but it's important to reiterate these, the same as folic acid. Smoking to reduce, but ideally to stop. And one thing I didn't mention there as well is vapes. Vapes, I suppose, is something that we're not 100% sure of in pregnancy particularly, so it would be recommended to avoid those completely as well. Avoid alcohol consumption when planning to conceive. It can affect your fertility, but it can also affect fetal development. And in some cases, people don't realize they're pregnant. So if there's a chance that you may become pregnant or you're planning, it's best to avoid altogether. And again, recreational drugs, again, affecting fertility, affecting pregnancy outcomes, and having a negative effect on the fetus. With regards to vaccinations and health screening, so with vaccinations, most people of a certain age will have had their MMR vaccine as a child, but often rubella, the R part of the MMR, that immunity can wane for a certain number of reasons, but particularly in people who are immunosuppressed, whether through a medication or through a disease process, often your rubella immunity can reduce. So you can actually get that rubella immunity checked with your GP or your healthcare service. And if your antibody level is very low, you can be offered the MMR vaccine again. The MMR vaccine is actually a live vaccine, so we wouldn't recommend you get that while pregnant. So at least 1 month before conceiving is optimal for MMR. Other health screenings such as cervical check, again, another important initiative in Ireland. Cervical check, you can actually check on the website when you are next due, because often we can forget. The recommendations are changing. It used to be every 3 years, now it's every 5 years, depending on your last result. So it's important to get that checked, because we don't routinely screen in pregnancy, because the results would be affected by the pregnancy hormones. So it would be best to try and make sure that that's all up to date before becoming pregnant. And then as regards your sexual health, sexually transmitted infections, they're important to be treated because, number one, they can affect your fertility, a high risk of pelvic inflammatory disease, which can cause its own set of problems. But also certain sexually transmitted infections can be problematic for the fetus during a pregnancy. They can pass to baby during pregnancy or during delivery. So it's important to have those investigated and treated in a timely manner. And then as regards mental health, this is something I think that's very important for us to address when it comes to preconception, especially for people who suffer a chronic medical disease. Chronic pain can be very difficult to deal with, the disease process itself, the uncertainty around the disease, and the pain aspect of it. So it's important that we all as healthcare professionals do address mental health concerns and manage it well. So there's a lot of things we can do to help: the complementary therapies, exercise, again, counselling, and then medications. They're an important part of the treatment plan for mental health. And mental health itself can be affected by pregnancy for the first time, or it can be exacerbated by a pregnancy. So that's why I suppose it's important to touch on that as something to address before becoming pregnant. Stress management, again, stress can be another issue. Stress planning to become pregnant, stress around not becoming pregnant and having to consider fertility treatment. So again, I know it's easier said than done in a lot of cases, but it's important to try and address these as much as possible just to help overall wellness. And then consultation with healthcare providers. And this is where I suppose myself and Louise would see a lot of women come through our service, and we're very lucky to have the service that we have in the National Maternity Hospital and the Rose Clinic. Because I know and I'm conscious that it's not something that's available to everyone around the country. For most people, the first port of call would be the GP, would be your GP, to talk about your pregnancy plans, to get advice. They may link you back in with your rheumatologist, or you may book yourself back in with your rheumatologist or your nurse practitioner to discuss this. Medication review is very important again, and that's something we'll touch on later, specifically regarding medications. But it's important to review those and know that they're safe, so that you can not have to worry then when it comes to planning your pregnancy. And then talking to your GP about genetic counselling, if unrelated to rheumatoid disease, that you have a family history of anything genetic. It's important to kind of look into things like that before becoming pregnant. And one thing I suppose as well, we don't often see ourselves in the maternity service, and gave me food for thought when thinking about this, was it isn't just about the women. It's for men, whether they have rheumatological disease or not, it's important that they're part of the process as well when it comes to pregnancy planning. Men with rheumatological disease can have issues with sperm quality, libido, and active flares can have an effect on these things. They may reduce their fertility due to testicular involvement or immunosuppressant use, and again, sexual dysfunction as a result of some of the disease processes. So a lot of the same advice applies for men when it comes to the preconception period. Diet, eating a healthy, balanced diet, maintaining a healthy weight, again, to help improve your sperm count and to help maintain proper testosterone levels, and then aiming for a healthy body mass index. Harmful substances, again, substance misuse, we'd recommend avoiding smoking. Smoking can affect sperm quality, its DNA, its motility. recreational drugs, again, cannabis, any of these things. And I suppose some of these things are very tailored towards the male side with anabolic steroids. I know that's something that women can be using as well, but they would have an effect on fertility. Alcohol will affect testosterone levels and sperm production, and then environmental exposures as well. Health checkup will be important. Again, if someone doesn't have any chronic disease, men particularly would be known to not generally attend their GP for health screening. So it would be important to address that if there were any concerns. Again, medications can affect sperm quality because, as we would see here, sperm regeneration, it takes a good while. So important to implement positive lifestyle changes early to have a positive effect on the sperm quality in about 3 months' time when you will be planning to become pregnant. Mental health, again, for men, no more than anyone else, it's important to address that because that can affect hormone levels again and sexual function. And one thing I would say as well, and I would see a lot of, which is really nice in our service, is that we see couples come together to the appointments. We always encourage partners attend for preconception counselling in the hospital to be part of the preconception journey together. Encourage each other with your healthy shared habits. And again, attending appointments together, whether it's with the GP, rheumatologist, or the obstetric service, so that everybody is on the same page when it comes to the advice that you are given. And then hopefully the next step would be a positive pregnancy test. So what do you need to do when you become pregnant or when you find out you're pregnant? Simple thing is just continue your folic acid, continue your regular medications unless they're contraindicated. Oftentimes pregnancies can be unplanned, so it's important to check. If you're not 100% sure, check with your GP or check with your service about your medications. Contact your GP just to register for the maternity and infant care scheme. That's the national scheme that everybody is entitled to, regardless of whether you plan public, private, or semi-private care in the maternity service. That's important also for your baby's postnatal checks for the 2 and 6 week checks. So everybody should register with the GP. And then register with your maternity hospital. For your maternity hospital, if you register yourself online or over the phone, it's important to logical disorder because your booking will be inadvertently to low risk clinics, so they may not be booked in to the appropriate clinic. So I would suggest maybe get your GP to send in a referral with a copy of some of your rheumatology clinic letters, so that you can be booked into the right clinic. Inform your rheumatology team that you are pregnant. Again, just to get linked in so that you maybe will get a visit with your team antenatally. Early things that may occur before you get to see anybody in the maternity service: nausea and vomiting. It's important to try and eat small meals often, try ginger, acupuncture, pressure bands. But now also contact your GP because Caraban is a very useful medication that people find when it comes to nausea, vomiting in the first trimester when it's affecting your daily life. Fatigue is something that happens in the early stages of pregnancy, so rest when you can. It is a common thing and it usually improves by the second trimester, but again, in the context of chronic disease, it may be exacerbated. So just be kind to yourselves and rest when you can. Continue your light to moderate exercise. Anything that you would have been doing before becoming pregnant is okay while you're pregnant. It's just not taking on anything active or a high impact when you are pregnant. Again, like that, avoiding high risk sports or activities with any risk. So with that said, I'm going to now hand you over to Louise, who's going to bring us into the next stage of the pregnancy and fertility journey.
Yeah. Thank you, Celine. Sure. Sorry.
Thanks so much for that presentation, Celine. That was very, very comprehensive overview. I'll hand over to you now, Louise.
Thank you.
Okay. Can you hear me?
Yeah, we can hear you, Louise.
Yeah. Sorry, I put on earphones. I just thought it might be better. Thank you very much, Celine. That was an excellent overview and a good grounding for what we're going to talk about in during this presentation. So, in relation to, I suppose, where we fit, and certainly I'm coming from the rheumatology perspective, and sort of in the lifespan of rheumatic disease, I suppose we've got better, certainly in the rheumatology setting. We have our pediatric rheumatologists, we have our transition clinics, we have our reproductive health care. We have a big interest now in menopause and rheumatic disease, so that's going to be the next big area of interest. So I suppose this has been a big shift in change in how we look after people with rheumatic disease during their different life stages. So I'm just going to move that out of there so I can see my slides. And yeah, perfect. So why is reproductive health care important? So we know, and certainly I know from 30 years working with mainly women in the rheumatology units, that pregnancy and childbearing is an important life goal for most women. And for most women, it is an expectation. We have certainly over the last 15 years, a better understanding of the disease process. We have improved access to healthcare and better medication management, which in turn has led to improved function and quality of life for women with rheumatic disease. So again, 20 years ago when we were working in the infliximab suites, I would have met lots of women who had told me that they were advised not to conceive because of their rheumatic disease. And thankfully that day is gone. We know now that most women will have no problem, getting pregnant and fulfilling their family planning. So again, to reiterate and to highlight what Celine said, preconception planning is absolute and important, is so important to ensure the best outcome for mother with rheumatic disease as well as delivery of a healthy baby. And as I had previously mentioned, that really is a sort of a new way of thinking about rheumatology care over the last 15 years. And a lot of women pre the beginning of the century were often advised not to pursue pregnancy due to possible risks of maternal and fetal morbidity and mortality. So we really have come a long way. So this is sort of a good time to be thinking about pregnancy. So who is there to support you when family planning during pregnancy and the postpartum period? And this is sort of from an Irish document that we were involved in. So again, the most important person in this whole cycle is you, the patient, you who is planning a pregnancy. And we really are there to support you with you achieving your pregnancy goals. So whether that be the obstetrician, the physiotherapist, the pharmacist, the specialist nurse, the rheumatologist, the midwife, we are all there, possibly at different stages. So as Celine said, myself and Celine work in a joint clinic. So we're there in the clinic together with Professor McAuliffe and with our rheumatologist. So we're in the one setting. However, there are different times where we might refer to physiotherapy because that might be appropriate, or we may need to send somebody to OT or perinatal mental health. So again, it's a broad team. But I need you I need to emphasize the important person in this whole team is you, and we're there to support you in your pregnancy plans. And of course, not to forget our partners and our family and friends who are, huge supports, sort of when anybody, never mind living with rheumatic disease, but when anybody is going through pregnancy. So the key focus in providing care, and this is sort of the key message, and really there's nothing really more that if you don't get anything else out of this presentation, this is sort of the key point. It is acknowledged, and there's nobody to say anything different, that quiescent or inactive inflammatory disease prior to conception is essential good disease control for the mother and a safe pregnancy and deliver on birth of a healthy baby. So everybody's going to, your rheumatology team are going to be talking all the time about having your disease well controlled. We know poor disease control prior to conception and during pregnancy may increase risks, as Celine said, of small for gestational age, preterm delivery, may interfere with fertility, may also increase the risk of preeclampsia. So from a rheumatology perspective, our gaze is very much on keeping your disease nice and quiet. So what is the impact of pregnancy on disease activity? So again, if we take, you can have a read of this, but certainly we just take rheumatoid arthritis, for example. The major clinical symptom of rheumatoid arthritis is joint pain, swelling, evidence of synovitis, early morning stiffness, fatigue. So we know the impact of pregnancy on disease activity. We know for women who are rheumatoid factor positive and CCP positive that 50% of those women will achieve good disease control during pregnancy. If rheumatoid factor and CCP are negative, then there is these women, 75% of them will achieve remission during pregnancy. And I think probably a lot of you have heard that you know, when you become pregnant, your disease can dissipate. That is true for a lot of people, but again, we're always very conscious that some people may not achieve good disease control. And the need for medication management during pregnancy, certainly we tend to continue now with medications that are compatible with pregnancy. And sometimes there can be dose alterations, you know, for example, you know, if somebody is very well, we might, you know, extend the dose of their TNF inhibitors. So instead of taking every 2 weeks, we might say, if you're doing well, we push it out to every 3 weeks. But again, that is a discussion with your rheumatologist and your obstetrician. If we think of, we just have a look at lupus. Now, lupus is a little bit different. We know the main feature of lupus is skin disease, arthritis, renal disease. There can be hematological issues as well as central nervous system events. We know that lupus can become more active during pregnancy. So again, we tend to monitor these patients very, very carefully. Medications may need to be continued, most likely will need to be continued, and doses may need to be altered. And just again with Sjogren's, again, why Sjogren's? We check everybody for a particular antibody called Rho and La. And this antibody is present in Sjogren's. Sjogren's is the main clinical feature of Sjogren's is dry eyes and dry mouth. So if somebody is on Plaquenil, so hydroxychloroquine, prior to becoming pregnant, we tend to leave them on that medication. But if they are Rho or La, or if they're Rho positive, we tend to start them on hydroxychloroquine to reduce the risk of congenital heart block for this patient group. So how do we achieve and maintain disease control? So a lot of the emphasis over the last 15 years has been that about medications and what medications are safe to use, because again, women have been excluded and are excluded from clinical trials. So there isn't a whole lot of evidence of medication usage. However, now, over the years, there has been lots of case reports and case series and combined experience from rheumatology and rheumatology, dermatology, and gastroenterology of their use during pregnancy. So only this in the last month, EULAR, which is our European professional body, has published recommendations for the use of antirheumatic drugs in pregnancy. So that is available, and really, I've left this slide here that you can Google these. You can Google these and find access to the information that we're going to talk about. The other guideline that we tend to use a lot is the British Society of Rheumatology guideline on prescribing drugs in pregnancy. So that's, again, if you want to, you can Google British Society of Rheumatology guideline on prescribing, and up it pops. I tend to, in clinical practice, I tend to, when we're having our consultation, to share these with people who are preconception planning, so they can see where this information, where I'm getting this information and where the evidence is about their use during pregnancy. So it's really important that you sort of feel confident about the information that you're getting. So for the purpose of today, we're not going to go through the full paper, but just this is a table, a quick reference table from the British Society Society of Rheumatology Prescribing Guidelines. And I've highlighted, I suppose, sort of the commonest ones we get a lot of questions about. So prednisolone, for example, so delta-cortical is compatible around conception. I can use my pointer here during the first trimester, second and third trimester, and is compatible with breastfeeding. And what they have done is they have a nice little section for male exposure. So if a male patient is planning a pregnancy, sort of he has some good evidence. And you can see there's a lot of medications that are compatible with pregnancy for men. The only one that isn't is cyclophosphamide. Hydroxychloroquine, we tend to use a lot of hydroxychloroquine in our pregnancy cohort. So again, it's compatible with all trimesters. Methotrexate, now this is one that you might have heard different advice along the way. So again, I've told you how long I'm working in rheumatology. So when I started in rheumatology, it was the normal advice was that you needed to be off methotrexate, no matter what dose it was, whether it was 7 milligrams, 7.5 milligrams or 25 milligrams, you needed to be off it for 6 months. And that switched again, that information, that advice changed a few years ago that you only needed to be off it for 3 months. Now with more evidence and in view of the amount of the dose that we use of methotrexate in rheumatology is quite tiny. The advice is that it needs to be stopped for women around at least a month prior to planning a pregnancy. Because if you think about it, if you have to come off methotrexate for 6 months and it has been keeping your disease well controlled, what's going to happen? More than likely you'll be okay for 3 months, and then lo and behold, you will develop, your arthritis will start to flare, which then will impede you becoming pregnant in the first place. And if you become pregnant, we know that you're less likely to have good disease control during pregnancy. So certainly there's been a lot of talk and discussion about methotrexate, and that is the current advice. But that's just, I suppose, the minimum amount of time. Just because you stop at a month prior to conception doesn't mean that you're going to get pregnant the next month. We know that sort of it can take a few months for you to become pregnant. And usually if they're stopping methotrexate, if your clinicians are stopping methotrexate, they're probably suggesting you start something else just to maintain good disease control. The other key group that I've highlighted is the TNF medications. So again, if you can see, we're quite comfortable with their use around pregnancy, around in the first trimester, the second and third trimester, and can be used, and women are encouraged to breastfeed while on these medications. It shouldn't be a barrier. Being on a TNF inhibitor shouldn't be a barrier to breastfeeding. And certainly in the 2020, the new EULAR guidelines, again, they are emphasizing that with these medications, there is no need to delay live vaccinations for your baby. So we're learning more as we're gathering more information. And I suppose just to remember that a lot of the medications that we stopped in rheumatology in the past were stopped not because there was any evidence of harm, but there was no evidence that they were safe. So again, as we are gaining more information, sort of, new guidelines come on board. Certainly with the other biologic, DMARD, so rituximab, certainly can be considered. So what they're doing is they're allowing the clinician to make the decision. It can be stopped at conception, but if you have active disease during the first trimester or the second and third trimester, it can be used. So again, it highlights to the clinician that yes, these can be used if needed, because the focus is, as you remember me saying before, is of having good disease control at whatever cost. I just want to move on a little bit to women's experience of care, because again, a lot of the the literature and a lot of the interest in the past has been about medications. But I know, and as does Celine, working with women with rheumatic disease and during this time, that there's more to it than just medications. So back in 2013, when I did my master's, sort of when I did my qualitative piece, the main themes that came to the fore were women they were dissatisfied with the varying approaches to medication management and care provided even within a centre. So you might go to see the rheumatologist today, you might see the SHO the next day, you might see the nurse, and even within the one centre, everybody was saying something different. So how can you make an informed decision when you're not getting good, clear advice? There was no visible evidence of shared care among rheumatology and obstetric clinicians, so hence the development of our Rose Clinic. So we're all in the one room, everybody's hearing what everybody's saying. And so what women found is that there was certainly that lack of opportunity to discuss concerns of pregnancy plans in busy rheumatology clinics. And those of you who attend rheumatology clinics know, that they tend to be busy. Women had said to me, look, I know I hadn't time to say anything because I knew that there was 25 other patients outside. So again, we sort of are working to try and change that. So here we go, that's 2013. So here we have another article, 2024. And here we have the same themes coming to the fore. And again, this was looking at women with lots of chronic diseases. So rheumatic disease, neurological disease, endocrinology issues. So again, these are women with chronic diseases and what they wanted for change. So they identified the lack of support. There was inadequate specialist discussion. So the same stuff. Suboptimal coordination in the care pathway. Who's responsible for what? And certainly one of the key recommendations is that need to empower women and to manage this. And I think we need to do a lot. And we are continuing to do a lot to sort of improve this, but it is taking time. And then I found this particular article, which is actually titled, Women Felt It's Monitored but Not Sufficiently Guided. And again, that was the overarching theme, with the main themes was feeling abandoned after birth. So during that time in the obstetric services, and you're going to your GP, and then you're going back to the maternity hospital, and the rheumatologist wants to see you. There's a lot of appointments happening, and then all of a sudden that dissipates once your baby is born, and you're sort of sometimes left on your own. You have access to your rheumatology team, of course, and we're going to talk about that. Women. And I actually spoke to a woman about this today. She attends multiple services for different issues, for different comorbidities, and that frustration of being the messenger and the interpreter and sort of bringing information from the rheumatologist to the obstetrician, if they're not all in the one room, and trying to make sure that everybody's kept on board. And then one of the other issues was that the chronic condition determined the pregnancy care. And sort of women express that wish, that worry and that insecurity about pregnancy, and having good support in relation to that. So I thought they were very, very interesting, and I think it's important, while we know a lot about medications now, that we don't forget that there is that other piece of supporting women through pregnancy. So we're on to the postpartum care piece. So this is what we all thought having a baby was going to be like, and it was all going to be glorious, and it is glorious, but it can be a little bit like this, and sometimes, a little bit chaotic. So we're aiming for something in the middle. We're aiming for something more normal. So what is a postpartum flare? So a postpartum flare is an increase in disease activity and disease symptoms in the period up to 6 months after delivery. And this is, and I found this picture just on stock images, and I just thought this was sort of typical of a mum who has a new baby and has young children in the house, and everything is going on. So she hasn't got time for a postpartum flare. When I saw this picture, I went, this woman hasn't got time for a postpartum flare. So we need to have you as well supported and prepared, and know what to do and how to access, so that you can get on with the job of looking after your baby and rearing your children. So a little bit of the summary of what the postpartum flare. So with rheumatoid arthritis, the risk of postpartum flare is up to 50%. But look at the risk factors for the flare. Stopping the TNF therapy too early, and poor disease control of conception. And that's going to be the theme. Ankylosing spondylitis, the risk of postpartum flare is quite high, up to 90%. But the risk factors for that flare, again, is stopping the TNF therapy too early and poor disease control of conception. The same with psoriatic arthritis. So the common theme is about not having good disease control and stopping medications unnecessarily. So key points to consider, and this is just a rehash of what Celine had said and what I have been chatting about. So ideally, if you do nothing or get nothing from this presentation, I would hope your rheumatology would inquire about your fertility planning. However, if they don't, please feel empowered to bring up the topic. I know clinics are busy, but certainly as you sort of start the consultation, say, look at, when I just want to chat to you about pregnancy, sort of, when you've done my joints and you've done my prescription and looked at my bloods, I want to have a chat about conception. Everybody is amenable to that. Remember, good disease control, that is the only, it's the key, one of the key points from what Celine said and what I have reiterated. Is essential to ensure best outcome for you and for your baby. Medications may need to be reviewed. Don't be surprised. You may need further monitoring from the multidisciplinary team during pregnancy. And I suppose just to highlight that no two pregnancies are the same. You can have two women, similar age, similar diagnosis, and their pregnancy courses can be very different. So again, this is why it is very much an individualized approach to care. So, as how you present is how we deal with you. Breastfeeding is to be encouraged. Absolutely. So certainly we had done some work in the clinic, when it started, and really only 28% of our women were breastfeeding at that time. However, and a lot of work has gone in about, getting the message across that breastfeeding is to be encouraged. So no doubt in time we will be re-looking at those figures, and we would certainly hope that our breastfeeding rates have improved, because that was diabolical. And then treatment choices, as I said before, should be made collaboratively between the patient and the healthcare provider. And this is another key point. While some of you might be attending the Vincent service, there's lots of other services around the country. When you are meeting with your rheumatology team, make sure you have an appointment, a pre-planned appointment for them 6 weeks after your baby is born, so that it's in the book, so that you can monitor for a postpartum flare. Hopefully you don't have it, but at least you know that that appointment is coming and that things can be reassessed from that perspective. And then this is my final slide. This is nuggets of information from those who know. So these are just some of the patients that I asked over the last few weeks. I'm doing this presentation. What advice would you give? So really, some of it is quite straightforward. Let your rheumatology team know about your pregnancy plans, even if they don't ask. This is the thing that I'm not so good at, but I think a lot of people probably are better placed to speak about this, joining reputable social media groups. And again, we met with a patient partner at a recent conference. She's actually from Italy, and she sort of educated us all about what's going on out there in social media. So again, this is something maybe that we can look at sort of again. Although this was good, get fit. Nobody tells you how physical it is caring for a newborn. Keep asking questions so everything is clear. And don't, this could be for any mother, don't be shy about taking help from family and friends when offered. And certainly I would advise anybody to, no matter whether they're rheumatic disease or not, to take worthwhile help. Not somebody that's going to sit and drink coffee and watch you, but maybe who's going to come in and help you, especially in those first few weeks. Thank you so much. But that's me. Will I stop sharing now?
Yep, you can stop sharing. Thanks so much, Louise. That was a fantastic overview.
Fantastic, really brilliant.
Yeah, really good. I just introduced Maeve Coyle. Maeve is Health Information Officer at Arthritis Ireland, and Maeve is going to take over now to run through some questions. It struck me there, actually, Louise, I doubt if that lady got to finish or even have that cup of tea or coffee, but I sincerely hope she did. She might have needed someone to make it for her
The
even.
woman with the children hanging out of her. Yeah. Yeah. But imagine having a flare and feeling pain and, you know, having difficulty washing, you know, what, never mind washing or caring for your baby, but caring for yourself as well. So
Yeah.
again, you need to be very careful and mindful of that.
Yeah, absolutely. Yeah. I think it can't be overstated the importance of planning ahead by the sounds of it between preconception and then even when you're pregnant to have those appointments in place and those supports in place. You know, it sounds like it's a really important component of it. Okay, so look, we've
Okay.
opened it up for questions and maybe, I don't know if you want to,
Sure.
go ahead there?
I'll go ahead. So, yeah, we've about 15 minutes left for questions. So one of the questions that came in, and between yourselves, Celine and Louise, you might decide who wants to answer each one. The first one being, can arthritis affect labour and delivery, the type of delivery that I have? And will my mobility issues or joint pain create an additional challenge for that?
Can you take that, Celine?
Yeah, I suppose like that we would have looked after a lot of women with mobility issues. We've had people who've had bilateral hip replacements, and again the question arose around mode of delivery. We've had people and they've had vaginal deliveries, no problem. We really do work individually with our labour ward managers and midwives. They often will see people antenatally to check even very practically positioning, talking about range of movement, how people will manage in that second stage of labour when it comes to having babies. So we've had people with a multitude of mobility issues and they've had very good outcomes as regards of vaginal delivery. So again, it's very individualised, but there wouldn't be any need to have a planned caesarean section in the majority of cases for these women.
Excellent. Yeah, I'd say that tip of prioritizing getting a bit fitter during the pregnancy,
Yeah,
without pushing it too much, probably really stand to a woman, I suppose, when it comes to any woman when it comes to delivery. Thanks for that, Celine. And might be for you, Louise, but you guys can decide. So you talked there about flares, and that's always very interesting. Somebody wrote in saying, I'm worried about having a flare and experience a return of that debilitating fatigue that I used to have after conception, plus the risk then of postnatal depression. Any advice for if that kind of rears its head for a woman that's going through the physical and the emotional burden of the flare, plus having to deal with a newborn baby?
And this person isn't alone in that, because people will remember what it was like beforehand. But I suppose, you know, while there's no, we can't look into the future, I think what we need to do is put things in place so that should you have a flare, that you have access back to whoever you need to go back to, that they can see you. It might be worth, if the baby hasn't delivered, it might be worth having that discussion with your rheumatologist. Sometimes they might suggest, well, look at it, let's restart. If you have been off your TNF inhibitor, let's restart it, you know, as soon as, you know, if you have an abdominal wound, we would certainly suggest that you wait until that is healed before you restart. But, you know, to sort of have that plan and be able to, I suppose, share directly with those who are looking after something. I'm worried about a flare. What am I going to do if I have a flare? If it happens that, you know, it's a bit like having the Calpol in the press. When you never need it when it is in the press, but you needed it. You know, when you don't have it, that's when you want it on a Saturday night. So it's about having that you know, that plan in place. I know what if this happens, this is my next step. Again, you know, and planning for flare. And again, some of the evidence, even though there were quite, you know, recent papers at this conference that we were at a few weeks ago, they're reckoning, because we're using our biologics, we're not stopping our medications. 10 years ago, we were stopping our medications, we were seeing flares. Whereas now the feeling, and we will have papers to corroborate with this in time, that those who have stayed on their biologic, this is the theory, that those who have stayed on their biologic or their medications throughout pregnancy, in theory, this will be looked at, you know, they should have less flares. So again, keep having that chat with your rheumatologist. In relation to mental health, I certainly would be sharing that with your rheumatologist and with your obstetric services, because I know certainly in Holles Street they have the perinatal mental health team, which are superb. And if that's what you're worried about, certainly I would bring that forward. Have that courage, and that's, believe you, that there's nothing any of us have heard, and Celine will agree with me on this. There is nothing we haven't heard, or your clinicians haven't heard of, but feel free to mention it, and then the appropriate steps can happen. Would you agree, Celine?
Yeah, definitely. Yeah, it's important to bring it up like that. There's a lot of services there, and it can be very daunting to bring it up, but again, completely non-judgmental, just there to support people. So it's important.
Yeah. And as you said, Louise, on one of your slides, the support, having support in place and accepting help when it's offered, and that's a really good, important point.
Absolutely. Get talking to it. Now, again, you know, outside even outside of the rheumatology community, you might have your friends or your cousins or your sisters or whoever who you know could be there to support you, and to have that in place, certainly if you're worried. I think we need to talk a little bit more about it, and I think once you talk about it to somebody, you realize, well, actually, I feel exactly the same, and it's just that's how it snowballs. But there are lots of services out there, but it's how to access them. And people know how to access them.
Thank you. They're great answers. Thank you. And moving on to another question. I'm worried about my joint pain and how it'll affect my ability to breastfeed after having my baby. Are there any accessories that you can recommend to help?
Yeah, now I can share, because our OT colleagues, so whatever rheumatology department you're in, there will be OTs there. But certainly we rely a lot on our occupational therapy colleagues to support, to give advice, certainly about holding baby, using pillows. Sometimes they meet with them and with baby to help latch the baby on. Do you have them in Holles Street, Celine? Do you have occupational therapists, or who looks after that in Holles Street or in the maternity
again, it would be, say, the lactation consultants, because that's one issue where we don't have OT, and that, specifically for maternity service. And it's something actually that recently has been cropping up. It is something that we do need to look at and will be looking at in our service. But our lactation consultants are really good, because even for people who have had a cesarean section or who have other issues, that it's to help people with positioning, with feeding. It's often about, different type of holds, helping people feed the baby while lying down. Maybe that's a little bit more comfortable. So the lactation consultants are very good when it comes to that in the hospital, very practical.
So there's two. So within your rheumatology department, think of your OTs. And certainly within the maternity hospitals, then you have the lactation consultants, and lactation consultants in every hospital. Again, I'm showing my ignorance.
Generally, they would be, especially with the baby-friendly hospital initiative. It's really promoted to try and improve breastfeeding rates in the maternity unit. So yeah, most places would have access. Yeah, and every registered midwife who's working in the maternity service, generally they complete a set amount of training to bring them up to a certain standard when it comes to supporting breastfeeding. So, like, even if it's not the lactation consultant, the midwife looking after you on the ward will be really good at helping you when it comes to these things as well.
Great, so lots of support.
Yeah.
Another question: what is the risk statistically, I don't know if you can give this, of passing on my rheumatic disease to my baby if my partner has no family history? So this is somebody that's worried about.
Quite low, very low, and it's a topic that we worked on at one of these conferences. So very low, 3%.
Oh, that's low.
And it's between 3 and 5%. It varies. So again, we had a rheumatologist in our group she's from Italy, and she, was saying, her advice is, and I've heard Celine, our pediatric rheumatologist, say this, it is a small risk, but if it happens, and nobody can control whether it happens or not, you have lived with a rheumatic disease, so you can identify those signs and symptoms and ensure that your child will have access to the pediatric rheumatologist. So it's only in the last 20 years with pediatric rheumatologists in the country. So again, there is that path, but it is very low. It is very, very low.
Okay, that's
good. Be reassured from that perspective. And should it happen, there are there are, you know, there is a pathway for diagnosis.
Exactly. Okay, thanks, Louise. And Celine, for yourself, you were talking about folic acid. Somebody asked, they said, I hate taking supplements. Surely I can get enough folic acid from my diet if I concentrate on it.
We generally, yeah, like I know years ago they used to fortify certain foods and cereals and things like that with folic acid, but we can't really guarantee what you are getting in your food to quantify the amount of folic acid that you would be getting. So that's why we definitely would recommend taking it. And I suppose from talking to people about it, the side effects of it are minimal. You know, certain other multivitamins, iron and things like that can sometimes cause GI upset, but I haven't come across anybody have an issue with the folic acid. So really just to err on the side of caution, the benefit is definitely there for taking it exclusively.
Yeah, okay. And on the MMR, the rubella, somebody saying surely it lasts, I thought it lasts a whole lifetime when I got the MMR when I was a baby.
Yeah, like you will develop a certain amount of antibodies, but especially like that, it's often either the immune process of the disease or it's the immunosuppressant medication can affect our antibodies. And so it'll affect antibodies in kind of any type of antibodies we have. So the vaccination helps us create an antibody to rubella and other antibodies such as varicella with chickenpox and different things like that. But because rubella can cause such major congenital malformations, it's important. That's the main one we talk about with regards to pregnancy. So some women oftentimes find out only when they're pregnant that they have reduced rubella immunity, and it's after their baby's born we give them the MMR. Thankfully, the rates of rubella are low in Ireland, but we will see them start to creep up a little bit. You know, I suppose there's different cohorts coming from different parts of the world that maybe haven't the same vaccine schedules as us. So it could be that there will be a little bit more rubella circulating in the community in years to come. So I think it's important we kind of keep it to the fore in pregnancy planning.
Okay, thank you.
Can I just add to that, and certainly within our department, sometimes the problem can be we check rubella prior to pregnancy. However, it is worth checking it if anybody is about to start a biologic. Now, they're not maybe thinking of pregnancy at this minute, maybe down the line, but it's worth checking your rubella and having your vaccination before you start the biologic, because it's a live vaccine, you have to come off your injectable medications in advance to take the vaccination, so you can be quite a while off them. So ideally, if you're planning pregnancy, maybe not now, but maybe in 2 years' time, you know, even have it checked now so that you know where you are and that it's not a surprise. You arrive up to the maternity hospital as pregnant, they check your rubella and find out that you're not immune, and you think, oh my gosh, I need to be careful. So that would be the advice.
So again, going back all to the planning, how important it is to plan, think ahead. Yeah.
Yeah.
Yeah, if that's something, thank you. Okay. And then we'll probably come up to the last question now. Any advice from either of you on alternative therapies like acupuncture or prenatal yoga? Do you see this as beneficial for women who are pregnant with arthritis? And do you see that in your clinics, that you think that that's really helpful?
Will I take that, Celine?
Yeah, you take that, yeah.
So certainly with absolutely prenatal yoga, there's again just with Pilates as well. If you're going to a Pilates class, remind there is specific prenatal and antenatal Pilates classes, but if you are pregnant and you're attending like I'm thinking about my own Pilates class in the back end of nowhere, share that you're pregnant with your instructor and let them know that you are pregnant, that they might adjust sort of some of the exercises or say don't do that during pregnancy or whatever. So we certainly would see a lot of people who are doing yoga and Pilates, acupuncture. Again, I wouldn't let anybody do anything to me unless I told them I'm pregnant or I'm planning to get pregnant or whatever, so that they can advise you. Don't let anybody don't take anything unless but don't take anything without telling somebody, you know, what state you're in. Again, because it might make a difference. But absolutely, we see it in use quite a lot. Would you agree, Celine?
Yeah, definitely. Yeah, even just for pregnancy in general, acupuncture, you know, for helping with symptoms, nausea, reflexology, acupressure, they're all definitely very beneficial. So, and like Louise says, it's even just making sure you're going to a practitioner who's, you know, registered maybe in their field, and yeah, that would be an important thing to consider.
Excellent. I think they're really good answers to all those questions. Thank you. I think we've probably come up on time, have we, Tara?
I think we have, and I think what we'll just do is just wrap up, if that's okay. I'm just going to share our helpline number with you guys again just one more time, because I just want to make sure that everybody has that, and that's 0818 252 846. And also to mention our sponsor UCB, thank you so much for supporting this webinar series. It wouldn't be possible without their support. And just to mention also with our helpline that if you're pregnant, we have people there at our helpline is open Monday to Friday, 10 to 4 p.m. and they can provide you with support and emotional support and any, you know, anything that you may need. We don't give medical advice, but we have people there to support you emotionally as well, and to give you information that we may have access to regarding pregnancy as well as arthritis in general. And our website, of course, is a huge source of information if anybody needs any information. And I just want to thank you very, very much, Louise and Celine, for your time this evening. That was a really excellent webinar. I think we got a really good overview from preconception to pregnancy to postpartum. So thanks again for all your help, and a wonderful Q&A as well. And thanks to Maeve.
Thank you very much.
Have a very lovely evening, and thanks again, and thanks to everybody.
Thank you, Celine.
Thank you. Bye now.
Bye, everybody. Bye-bye.